Good evening, my good people. Come on in the room. Come on in, come on in. Come on in, let me know that you're here so I can shout you out. Got a minute or so to get started. Come on in the room. Yes. Comment, let me know you're here so I can see you and shout you out. You guys gotta tell me, do I look blue? Like I got on a blue stroke light. Hey, sis Robin, my fellow Nubian queen. Good to have you. Come on in, come on in. We have an amazing show, an amazing episode. I don't even know what to call these things, but it's amazing information for you guys tonight. So I want you to come on in, come on in, come on in. We have our Dr. Christina back with us. We have a lot to discuss and talk about. So come on in. I'm going to wait for a few more of you. Comment, let me know you're here. There's probably a delay if you're commenting and I haven't. I am beautifully blue. Okay, thank you, my sister. I'm not sure what's going on with the light today. I guess they want it to be blue. Good evening, Pastor Darling. My good old cuz is in the room. This is going to be important information if you know a male, if you are connected to a father, a husband, a son, a nephew, a godbrother. If you have any males that you are connected to, you need to be, hey, Deidre, hey, Teresa, you need to be on this show. You need to share this. If you have males in your house, cut it on, turn up the volume, let them hear it, okay? If you have males, and if you're on my page or on my ministry page and you're a male, you need to be a part of this conversation. You need to hear this information. This is a matter of life and death. And I'm not saying that to just be, I don't even know what word, exaggerated, but it really is. And we're going to talk about it, but this is information that everybody needs to know and needs to have, especially if you're connected to men that you love in your life. And yeah, so please share this episode on your page. Direct people to the ministry page so they can watch it, because again, this is critical information. This is life and death information, and as a community, we just can't continue to not be informed. Okay, so let me know you're in the room. Let me know you're in the room. This is really good information for you. I'm so blessed that our guest is willing to come back. She was willing to come back for another episode. Yay! And we'll bring her in the studio in a minute, but I just want to give us a chance to come on in so we can center and get ready to get started. I'm not going to wait much longer because we cover a lot in these episodes, and I try to keep them to an hour. At first, I started at 45 minutes, but then it just was so good. We ended up going to an hour, and I think even last week we might have went over a little. Hey, cuz. Hey, Key. We went over an hour, and so I'm trying to make sure that we stay kind of in this hour time frame. But again, this information is so critical, you can't afford to miss it. So please share it. Don't do a watch party, because then that'll take you out the comments and I won't be able to comment, highlight your comments. But definitely share it, right? Share it. Direct people to the ministry page. please, because this is critical information. So I'm going to go ahead and get started. Who's in the room is in the room, right? I don't count the numbers, and we can't wait for folk because we have so much to cover. There's so much to cover in this session. So welcome. I want us to go ahead and get started, and we'll start. Good evening, everyone. Thank you for being in the room. We are here in Tisa's Rants and Musings, and I'm excited about today's episode. I'm excited about this time that we're taking to dialogue about men's health. Our theme has been for the month of June, because June is Men's Health Awareness Month, but also because so much has happened with our men, especially our Black men. COVID hit men. So significantly worse than it hit women, and then if you look at just for Black men, walking the streets alone is not is actually taking a risk, taking your life into your own hands almost. So there's a lot happening for our men, and we learned last week so many different things from our guest, Dr. Christina Johnson. I've asked her to come on again, and let me just say how appreciative I am of all of the guests that come on and do multiple weeks, especially because she is a medical doctor. She is seeing patients. She is very busy, and she was willing to come and share her time with us so that we can be better informed. So I'm going to bring her on in and say, welcome, Dr. Christina.
Hi, everybody. I'm in the room. I hope everybody's doing well and that your family's doing well too. I really do hope that.
Thank you so much. Hey, Rosalind. Hey, Sister Alana. So we got the sisterhood definitely shows up, right? And that's typically how it works, right? That women, and that's part of what I put out there when I did the ad for today, that more likely than not, women are going to be the caretakers of people. Women are going to be the one left to make certain end of life decisions when our men are in crisis. And I don't know if we're having the discussions, one, to know what to ask and what to even know, but then oftentimes those decisions are being made in the moment. And I can just share with you guys, and I had shared it before, when my father was passing, they were asking, do you want a DNR? Do you want us to do hospice? And we hadn't had those discussions, so I didn't know what to say to know whether or not that's something he would have wanted. And I honestly don't think he had that discussion with his wife as well. So it's just but we're in this moment having to make this decision, and neither of us really know, like, I guess no. And so understanding how men have been impacted, so many women have been left in the same position where they're in the hospital, or even with COVID, you're on the phone trying to make a life-changing decision about the care of the man that you love and care about, and never even had that conversation, never, or don't even know the terms that they're talking about. And sometimes I find in hospital settings, Christina, they use those acronyms with an assumption that you might know. So when they ask us, would you like a DNR? I knew what it was. I don't know if she knew what it was, but you kind of in that moment, nobody wants to say, well, what's that?
What is that? Right.
You don't look stupid.
Yeah.
So you're left not knowing. Help us.
So we're going to cover the basics tonight, because I do think that from the standpoint of a provider in the outpatient setting, meaning I see patients in the office and I see patients in the hospital side. As soon as you come into the hospital, it doesn't matter what you're there for. If you need to be admitted to the hospital, they're going to start asking you these questions about what you want and what you don't want when it comes to the end of your life. And part of that is kind of deconstructing the way we think of hospitals. And it is true that people come to hospitals for healing. They come to hospitals to become cured of whatever illness that they're undergoing. But statistically, the numbers show that of the people who die in the United States, and remember this year it's going to be very skewed because of COVID, but in general, of the 2.3, 2.5, depending on the year, million people who die in the United States, just die in the United States of various causes, about a third of those people are in hospital care settings when they die.
Wow.
So people come to the hospital thinking they watch TV. They go, oh, well, I'm going to go to the hospital and I'm definitely going to live. And everyone who's on the medical team and everyone who sees a patient coming into the hospital, that is our full expectation that people live. But not everybody lives. Some people are dying on their way to the hospital. They're in a dying process.
Right.
It's to the point where they need to come into the hospital, right? And so then what we're doing is kind of facilitating an end, the terminal process, and making it comfortable or trying to reverse it, like when we do CPR, and we'll go over that in a second. So it's important to know that your medical team, and then let's kind of get into it. So, because I don't want to delay by doing analogies, but basically this is what happens. Your medical team's first priority is going to be to preserve your life. That's our baseline status, meaning if you were to come into the hospital setting and your heart were to suddenly stop, it doesn't matter how old you are or how sick you are, our first point of action is what we call CPR, cardiopulmonary resuscitation. That's where you see people on TV, they press down on your chest,
right,
for you, and that's because your heart and your brain, that's your life, and so they're trying to mimic the blood circulating around your body, and in particular the blood getting to your brain. So when your brain loses blood flow, it starts to die. Okay.
Right.
The problem with CPR is that it's not very effective. To be honest with you, it's not like TV. Thank you, Tisa. Not at all like TV. So what studies have found is that people who watch TV, like 75% of people who watch TV, they think, okay, if you just do CPR, the person you shock their heart, you press their chest, you breathe for them, you shock their heart, and boom, they sit up and go, whoa, that was tough. No, that's not what happens after someone is resuscitated. The actual statistical data show if you're younger, if you're in your 50s below, you have fewer medical conditions going on, then yes, you might. And if you're younger than that, then it could be a survivable event. And 70%, 80% of people, or even more than that, may survive, depending on the size of the study. But if you take the broad swath of the population in the hospital and outside of the hospital, it only works about 16% of the time, 10 to 16% of the time.
Okay.
Cardiopulmonary resuscitation.
So let me ask you, because when my father was in the hospital, they asked if we wanted DNR, and then they said to us they wouldn't suggest it because they were saying that CPR, it could break his ribs or it would be damaging. And I thought, how interesting. I thought CPR was a safe thing to do, or like you said, like TV would be the natural thing to do.
Right.
But they're saying it can be even more damaging.
Oh yeah, you're anatomically, your heart, this hard bone down the middle is your sternum, and your heart is beneath that bone. Surrounding that is your rib cage. So you have your heart and your lungs in a protected position. It's a protected organ. And so when we're doing CPR, you have to press down several inches in order to get the depth of actually pumping your heart enough to circulate the blood around your body. And so certainly in the course of doing that, it is true. And I'm a physician, I'm a family medicine doctor. So that family medicine doctors study the broad swath of taking care of patients. So we do inpatient care, we've done codes and CPR. We have to do all of that, like actively do all of that in the hospital setting. And so we are literally pressing several inches, 3 to 4 inches, 4 inches optimally on a person's chest rapidly, and you feel I don't want to be morbid, but you feel the breaking of the ribs. And somebody coming into CPR, like what brings them into CPR and needing resuscitation is often what can kind of dictate whether or not they're going to survive that event. You know, if you already have pre-existing really severe heart disease and lung disease, and you're on dialysis and, you know, all of these other things, and your chance of survivability is not as high. And that's not to say that you cannot survive, but your actual chances. And we have to be honest in telling you that, because even if we get the body to revive and we get the heart to spontaneously start again, that doesn't mean that that period where your brain hasn't gotten any oxygen, that's recoverable. That might be, you may not recover that brain function. So your body will be working. It's, you know,
Right.
your heart was beating when you were, it's one of the first things that starts when you're a fetus, that heartbeat. So your heart may keep beating, but you may have no cognitive function left. You may not be able to be alert or oriented in any measurable way.
So let me ask you though, not to cut you off, but just to slow it down and so we could get all of this in there. Part of understanding, and why we're talking about understanding what CPR means, is so that we can be better informed if we want DNR or the AND or something like that, right? So just explain to us what DNR actually, when they asked me, do you want DNR? What were they really asking?
So when someone asks you whether or not you want the status of that patient in the hospital to be DNR, what you are saying is that you don't want that resuscitation. You don't want CPR.
CPR.
With CPR, and you should know this, with CPR, it's almost automatic that that person is going to be intubated as well. Meaning we're going to put a tube into the airway and hook them up to a machine to have them breathe. Because remember, I said when you do CPR, the brain may not quite come back, and so they may not have the regular respiratory function to know when to breathe and when not to breathe. So we have to breathe for them. So saying DNR often means that you are not going to, not often, it means you're not going to do that CPR procedure. Now there are different levels of CPR. So, I mean, DNR, I'm sorry, or do not resuscitate. So there's DNR-A, DNR-B, DNR-H, DNR-I, and basically they just sort of specify with greater detail what you do and don't want to do. So for example, DNR-B might mean for, in our hospital setting, it means that you still would admit a patient for care. Maybe they're there for a really bad urinary tract infection and they're going to be on antibiotics. But if at any point during that hospitalization their heart were to stop, we would not do CPR on that person. So they're still there for treatment. They're still undergoing treatment. They're still getting treatment for something. And it could even be something related to their heart, their lungs. Maybe they're having a cardiac procedure. But if something were to happen during that procedure, then we do not perform that resuscitation procedure during their hospitalization. And then, so some things are a DNR-H, so like you can not hospitalize. So some people, especially people in nursing homes, for example, or long-term care facilities, will decide, I don't want CPR and I do not want to go to the hospital because.
Go ahead.
No, go ahead.
Because I was going to say, it's such a huge decision, right? And I guess that's why we're having this conversation, because most of the people probably watching are, at least attached to me, are probably people of faith as well, right? So we have in our mind to do everything possible to keep the person alive, and see what God will do. And this is, kind of what was going on with my father. His wife wanted to just keep believing, and holding on to the faith that maybe God would intervene. But this is why that conversation is so critical, because if I'm 70 something with a terminal illness, I may not want that resuscitation because I don't want to still be in the hospital suffering. I'd rather go on and meet the Lord. Like, let me go home, go on and see Jesus. I'm good. Y'all, let me go, versus someone who's being moved by their emotions in the moment and still wanting that person to be alive for them, but to your point, may not even be alive where they have brain functioning.
Right.
So we need to have these conversations about these kind of things. But I remember learning about just something called the Advanced Directive. Like, well, part of all of this is in the context of this advanced directive. Can you tell us a little bit about what that is, and even how do you get started with getting one? Like, what do you even do?
So the advanced directives are written or verbal documents. So, if you think of a verbal document, it's I know what this person has said about their dying process, and I know what they do want and what they don't want. So an advanced directive states a couple of things. Optimally, it states who speaks for them. That's number one. We call that a healthcare proxy, or a power of attorney for healthcare, or a durable power of attorney for healthcare. If anything were to happen, they fall out on the street, nobody is around, a healthcare proxy is the person that we're going to call on the phone and say, listen, this is what's happening to this person, and this is the position that they're in medically. What do you want us to do or not do related to cardiac arrest, related to intubation? And it could also specify more things. It may specify, for example, whether or not there's certain tubes and feedings and other interventions that they want. And you alluded to this when you put DNR/A and D. And A and D from the clinical standpoint means allow natural death, meaning, and that's what DNR is, a do not resuscitate. It means that there's a dying process that's happening, and we're going to allow that process to take its course. It doesn't mean we're withdrawing care or we're stopping, things in the clinical setting. If we started something, that may be what it means. But sometimes it doesn't mean that. It means that we see that this is a dying process. We see that this person is dying. And so we're going to allow that process to happen. Returning to the healthcare proxy, the importance of the healthcare proxy is that the healthcare proxy is not communicating what they want for you in your dying process. They are dictating to the medical team what you wanted. You had a conversation and you watched a movie and somebody died, and you said, oh, and they had tubes, and I never want that. Or I never want to just be a vegetable. Or maybe they say, you do everything for me. Anything that keeps me alive, that's what I want. Whatever that person's wishes are, that's what the healthcare proxy is communicating. And sometimes people choose someone who they're very close to, but doesn't really have the sort of emotional strength to allow that person's wishes to come to the forefront when they're in a decision making, when they're in their place of having to make a decision. And so so some people, for example, it's like, oh, I have a favorite child or this or that, but that child will hold on to that person until there's no life left and still ask us to press on that chest. Some people go, this is my favorite child and they know me, but it's going to be Uncle so-and-so, or it's going to be Aunt so-and-so. It's going to be my best friend, or it's going to be this person, because they know that they love me. I know that they're not going to, cut the cord, as it were, or turn off the machine. They know that what I wanted was to not do this and to just do that, whatever this and that might be. So healthcare proxy is a very important thing, and it is in an advanced directive. It should be in an advanced directive. One of the things in an advanced directive. The additional components of advanced directives can vary because there's different kinds of advanced directives, but basically what it means is that you as a person are specifying what you want. That's what an advanced directive is. It is not, what somebody is telling you that you should have, unless you lose your decision-making capacity. All of these documents are to be written optimally when you yourself are the person who can specify what you want or what you don't want.
Right.
So a living will is
wait.
Okay.
Okay, wait, because you said something so critical right there. So I just want to reiterate that this is supposed to be happening. We're supposed to be writing it or getting this advanced directive when we are capable of making the decisions for what we want to happen should something happen to us.
Yeah.
What it seems like happens is, and again, especially with men who don't go to the doctor unless something's wrong, right? Or, and as COVID showed up, we don't have that conversation. So then these things are being made and decided upon in the moment. Mm-hmm. So since we're supposed to be having this conversation and having this kind of written out, and detail, where do we even start to know where do we get that? I remember when my father first had his first bout with cancer, I was his healthcare proxy, but I got that form from the hospital, and they gave it to me, and it was able to be on file so that he can, anytime I needed to talk to a doctor, because it even made a difference in who the doctor would speak to about what the treatment plan was.
That's right.
At one point he had so many people in the room that when I asked the doctor, what is going on, he was like, and who are you? Because there's so many people in there. I don't know, who's who.
All the time.
When I said, and he was single still then. So I was like, I would be his healthcare proxy, or can I get a form that would say, that I would be his healthcare proxy? But I didn't know before that where I should have had that. Like, so tell us, how do we even go about getting this stuff?
So there are some forms available right on the State of New Jersey website, the Department of Health. They actually have sort of preset forms that you can complete. Even if you just Googled New Jersey State Advanced Directive, it'll take you right to a website where there's a proxy directive where you can identify someone who as your healthcare proxy, where you can complete an advanced directive and get different forms directly on their website, so that you're using a form that can be recognized by medical providers. Some people, you don't necessarily have to have these things kind of like notarized, but the forms on the state website are usually a proxy form and a living will, which is a kind of advanced directive. And so those are freely available. They're Googleable. You can just pull those forms up directly. And to your point, the conversations are difficult because often in our communities, we don't even talk about, just how we're doing at all. We don't even know, someone has problem. Like nobody knows. Nobody talks about their medical history, their health history. And so you don't know until they're in the hospital. Oh, I guess he had the sugar and something. Nobody really understands what's going on and can make those informed decisions. But the first part is, and I found this to be the case, that if there's a child parent dynamic, and especially children like myself, 40s going into 50s, and you're starting to take care of elderly parents, or you're somehow wind up more involved in their care, I have the conversations with the child and say, how are your parents doing? Oh, they're okay, but she's getting ill and this and that. And we start the conversation in the clinical setting about what these documents are, and have you spoken with them about your wishes? And then 9 times out of 10, then I go, well, have you talked to your family about what you want? And then they go, but I'm only 40 or I'm only 50. And I don't like to think about that stuff. And I don't want to think about it. I said, I don't want to think about it either, but nobody wants to think about it or expects it. So one of the places is we have the conversation is in the clinical environment. The other place is that we can have the conversation sort of culturally, when we're talking about family members who passed away, we can open up a little bit. So how did they pass away? We don't know. Wow. We don't really know. Well, was she in the hospital? No. Okay. Well, do you know how it went for her? Did her heart stop? Did anybody have any paperwork for her or a directive? Now that you're having this conversation and we're talking about these terms, then you can introduce those things. The other cultural kind of moment, and to be honest with you, it's one that we do talk about, but we neglect it. When we're listening to songs and we're watching movies, we see these things happen. When we see TV, we watch television and it happens, and somebody has CPR. We watch a movie and it happens. There was a movie years ago, $1 Million Baby, where if you've not seen it, I'm not going to tell you the twist, but if you've not seen $1 Million Baby and you have a man in your house, especially a guy who's into sports, this is the kind of movie that you can watch. And surprisingly, the part of the twist of the movie has to do with these topics and these conversations. It's a great conversation starter. And it's a sports movie, so they'll actually like want to watch it. Like it really draws you. And I don't like sports like that, but it drew me in. I was like, oh, get it, girl. Like, I was into it too. So there are cultural moments to do it. When players die suddenly, when people in our communities die suddenly, those are opportunities. They're unfortunate opportunities. And even with COVID, there are opportunities to have us say, wow, so many people passed away. And, honey, I don't know if something happened, I wouldn't even know what you wanted. I wouldn't even know if you wanted to have the CPR, or you wanted tubes and lines and a tube in your throat, and how long, if they say you can come back, honey, what you want me to do?
In that state, right?
And they're not easy conversations. They're hard conversations to have. They're uncomfortable conversations. But like everything else, the more you have a conversation about it, I don't want to say the easier it gets, but the more openness there is. And you have to give people time to think. These documents are not like set in stone. And that means that if you decide today, I want everything done, and you go to the New Jersey website, you pull out the living will document, you specify, I want everything done. I want CPR, I want intubation. If there's a feeding tube, I want that. If there's, medications, I want every single possible thing. And that's what you specify. You sign it, and you have your healthcare proxy sign it, that they witness it. Then you say, okay, great, that's what I want. And then in 50 years or 20 years, you say, you know what? I'm not feeling that. When it's my time, it's my time. Then you write void on the page, tear it up, void, and then you pull another document and you fill it out based on what your wishes are at that point in your life. The point is that you are the driver. You make the decision. And I said living will because that's the one that's available on the New Jersey website. And it is there's an umbrella called Advanced Directive. And under Advanced Directive are a number of different things, but one of them is a living will. Again, it is written. It is a written form. So that's why it's on the New Jersey website and not just an Advanced Directive, which can be verbal. It could just be what someone told you. But you have to be cognitively intact. That's the assumption that you have made this decision. And these things don't kick into place unless you're not able to make a decision. So you're not going to come into the hospital, in need of some major medical procedure, and then you show me your Advanced Directive, and I go, oh, nope, because you said you didn't want it. Well, if you're alive and you're cognitively intact, and you say, no, I want that, then that we obey what you tell us that you want us to do. That document only kicks in when you can no longer tell us what you want, and then we abide by what you wanted when you could make your own medical decisions. So power of attorney is important. Understand what do not resuscitate means is important. Living will is the kind of document where you can kind of specify what you want and don't want. And you can get very specific. Like if you don't want feeding tubes, if you don't want any surgeries, if you don't want any procedures, if you, if you want to try CPR or try intubation and then decide, and then if there is no recoverable function, or if you have an irreversible condition, then you will choose to terminate any, additional processing. You can be very granular and very specific about what you want and what you don't want. The benefit of that is that the people who who are left, the people who are there, the healthcare proxy, the family members who come, they see that and they know this is what she or he wanted. There's a measure of peace with that. And to your point, Tisa, some of the hardest family conversations are had when there are 10 people around the bedside, and it's only an advanced directive, like a verbal. So we know that the daughter has been taking care of mom for 35 years. And then we're at a terminal process, and here comes cousin so-and-so and aunt so-and-so and niecey so-and-so and the neighbor and the this and the that. And everybody wants to come in and say what they think should be done. And if you don't write it down, it's harder, because then the daughter may feel pressure. The daughter may kind of go, well, maybe something can, and she knows what the mom wants.
Yeah.
or he knows, and if you know what your spouse wants, but it's not written down anywhere, then anyone can come up. And believe me, people come from out of nowhere and have something to say about these terminal processes, about the dying process.
Right.
They interject their own beliefs. They interject faith. They interject religion. They interject their suspicion of the healthcare system. They interject.
Okay. Wait. Let's stop right there, because historically in our culture there is a lot of suspicion and a lot of and distrust of the healthcare system, which is why this is even more critical, right? If you don't want to trust that you're going to get the care that you need, if you leave it up to the doctors in the hospital, this is even more important, because at least we as the family can know if they followed what your wishes were when they were written down, right? Yes. So it gives us that added insurance kind of like policy to say, did they follow what we said was the last wishes, the last request for the end of life, process. So I mean, I just think we have to, one, education is key, like you said, but I think we have to look at this differently now. This COVID thing, to me, where so many women were left on phones to make decisions that they wish they would have had. And nobody was prepared for this. Nobody was prepared for a pandemic. Nobody was prepared, and so you don't think to have the conversation. And now in a moment of crisis, when you're not even able to be with them, you're making this decision. And it's not always the best decision because it's misinformed, right? Mm-hmm. So I mean, I think you just set up the context for why this whole conversation is so critical. There was something else I wanted to ask you about, because I know we're talking about end of life and just being prepared for death. And again, it's such a difficult conversation, right? It sounds morbid. It sounds, I'm sure, more people are like, oh, they talking about dying. Like, I don't want to listen to that. But it sounds morbid. But I think maybe you can give us some tips. And I thought the $1 Million Baby movie was a good one, but give us some tips on how to change our thinking about this. Like what are some of the positives, outside of, because some people will say, well, I don't know if I care. I don't care if I'm dying. Y'all do what you think is best. And I've heard that. I've heard people say, you do what you think is best. I'm not here. If it works, it works. If it doesn't, it does. So if they don't care, then you left like, well, I don't know what to do. Mm-hmm. I feel like on my hand, I don't know what to do. Mm-hmm. But maybe there's some way that we can start changing our mindset about even how we think about these moments, right? About these crises. And again, not everything ends in death, but at least being adequately prepared. And I think in one of our lives I talk about as believers, I'm always so amazed how we have such a difficult time with death and dying. Like grandma could be 98, right? About to get to 100th birthday. She's in the hospital. She ready to go on. And everybody like, no, give us CPR. Like, when is it okay to go? And not, as believers, we tend to say, and I've said this before, we tend to say, we live this life to live again, and we believe in, that for me to live is Christ, to die is gain. But when it comes to death and dying, no, my friend said to me, everybody wants to see Jesus, but nobody want to die.
Right.
It's like we have such a hard time letting go. And I think it's probably a mindset, is there, because you doctors know how to do it. Are you trained to know how to look at this process differently? Like what tips can you give us to maybe change our mindset so that it's not so hard to talk about?
Right. So from the clinical standpoint, what we see, we try to step back, and particularly providers that are sort of preventive care or centered providers. So you have specialists who have their perspective, and the oncologist thinks one thing and the nephrologist thinks one thing, but as providers, we stand back and we take a look at the whole picture. And that's what's often very difficult for family members to do. Because they will latch on to like one thing, like, well, maybe the doctor said something about sodium levels. So if the sodium levels get fixed, then the person can come back. But really what we're saying is, let's take a step back and look at this person's life. what is this person's life like? A lot of times the dying process, the person is maybe not as active. They've become weaker. They don't eat as much. They're more fatigued. And sometimes it's just sudden. Like, so sometimes they're, especially in COVID, again, is an outlier because it just came from nowhere. And sometimes there's no rhyme or reason as to why people are dying beyond the factors we talked about last week. But one thing I try to encourage family members to do is to really just take a step back, and our conversations are allowing them to understand what dying looks like. People don't see it. We see dying. A lot of people don't.
Right. That's a good point.
They don't see it up close. They don't see the trajectory. They don't see the progression because they're just looking at somebody day to day, just like a child. You watch a little baby grow up every day, but if I'm auntie and I haven't seen you for 2 years, I go, whoa, you really grew up. And then the parent is like, oh, you know what? They have been getting bigger. Oh, look at that mustache. But it's like day to day, you don't see it. And it's the same thing with the dying process. People don't see dying. They don't see it realistically. And we also have homes where people are not necessarily, they may be tangentially involved in the care of elderly people, but not directly involved. So they don't see the physical decline. And then when they get into a hospital setting, you're able to step back and go, this is not a sudden event. This is not just something that happened. COVID, again, is an outlier. This is not like something that just suddenly happened.
Right.
Even things like heart disease, right? Heart disease is still the number one killer in the United States, even despite COVID. And again, the numbers are going to be skewed. It still kills 600,000 people, 630,000 people, like every year. That many people die from cardiovascular disease. And sometimes those events are abrupt, like they come out of nowhere. Somebody just dies. But
wait, just so I'm clear, when you say that's like having a massive heart attack and that.
A heart attack, massive heart attack, and then also in the top 10 are things like stroke. So those are also cardiovascular events, sudden. And what happens is those are more traumatizing often because it is a sudden event. The person is living their life and then suddenly they die. But a lot of people, you're getting your 70s, 80s, 90s. It's a gradual process. And so you don't see, you're looking up close at an event that has a trajectory. And so part of our job is to communicate that trajectory as they're going along. Things are slowing down. Your heart is slowing down. Your body is slowing down. This is part of a dying process. The other thing is to destigmatize dying. And to your point, there is a lot of justifiable there's a lot of justifiable reasons that we are skeptical about whether or not we're getting medical care and whether it's the right care. It's appropriate in the United States. We cannot divorce racism from experiments on how the pap smear was developed to radiation experiments in the 1940s to the syphilis experiments from the 30s to the 70s. So no, we have been experimented upon. There's a natural skepticism that comes born of our history.
And we just heard of those British doctors who said try the COVID vaccine on people in Africa.
Right, exactly. So
it's a legitimate
we cannot divorce our racist history from medicine. Racism is our common disease. It infiltrates everything. So we can't divorce it from medicine. But outside of that, we also carry culturally a stigma about dying. We see dying as, one, a threat to living. It is the opposite of the coin.
Right.
But we also see it as though there's something wrong. There's something wrong when we're dying. It's a process to get fixed. It's a disease to be cured. It's something we can recover from. The process is something that we can recover from. But at the end of the day, the mortality rate of human beings as a population, as a species, is 100%. If you are alive, you are going to die. It's hard to talk about. It's hard to think about. I don't want to think about it. I even still pray, like, Lord willing, Lord, if you get me to 50 or whatever, and it's realistic. You don't know. Nobody knows. It's the great unknown. And so we have this stigma about oh no, the person is dying. And yes, there are some traumatic deaths, there are some unexpected deaths, but a lot of people that are dying, they were already dying. They were just dying slowly. They
Right.
were
So
they
let
were
me ask you about this then. And I don't, forgive me for cutting in right there.
okay.
So then explain to me hospice, right? Because I think, again, when it comes to, and I've heard different things about, it almost is a stigma for hospice. It kind of resonates for people as if you've given up hope.
Right, right,
And if this is someone who you've been kind of holding faith to believe in God, that God will raise this person up, moving them then into hospice almost feels antithetical to faith, right? It feels as if you're now saying we've given up, that God's going to do it, and so we don't make that movement.
right,
But having the experience I had just had with my father, they kept saying and wanting to do hospice, and we didn't, she didn't want to go that way, but it made me rethink hospice, right? It just made me think of, how do we want to die, right? Do I want to die with a certain level of dignity? Do I want to die with a certain level of feeling like I'm comfortable, I'm not suffering, I'm not, in a space where it just feels like, I'm struggling for something that's not really possible to
right,
happen. So how do we, how do we normalize, or maybe just explain what hospice really is? Because people just think of it as the death where you go to die,
right,
and then again it has this negative connotation. But maybe again, if we understood things better, and I just want to put this all still in the context that this conversation isn't really about death and dying as much as it is about preparing for
right,
for what could be the inevitable, right? It is appointed unto man once to die.
right,
And since this is happening and is gonna happen, and it's so hard, and it will be, your family's gonna be grieving, people are going to be really sad, to see this happening to a loved one. How do we make it easier for them to allow what might be happening naturally? Because we're dying every day. Every day that we get older is a dying process, right? So how do we do all of this so that people are prepared and can focus more on grieving than trying to grieve and figure out how to keep you alive and all of that? So I just wanted to really put that out there so that people can understand that this is not just about death and dying. This is about preparing ourselves and getting ready for that day that God may call us home, right?
yeah.
So maybe
So,
you can explain
so
hospice for us.
right. So hospice is, if you think of, you should think of hospice as a medical team that comes along to walk alongside you as a family and the patient during their dying process. In the United States, hospice is associated with, if you have Medicare, you have Medicare Part A, there's a benefit that comes with having Medicare Part A, which is hospice. And it includes a sort of bulk number of services that are associated with the patient during their dying process. And we know, that's how we see hospice as a benefit, because it is a team. Dying is hard. It's hard on the family as the body fails and the body's functions are failing. That's difficult. And then we already know, there have been plenty of studies that show us that there are certain trajectories associated with certain kinds of death. So there's a trajectory associated with cancer where there may be a period where they just sort of slowly decline, and then there's a drop. There's other sort of chronic illnesses like congestive heart failure where they kind of do okay, or COPD, or chronic obstructive pulmonary disease, where they do okay, and then there's an infection, and then they kind of down here, that's their new baseline, and then they do okay, and then they drop again, there's something else that happens. And so we know these trajectories, and the point of hospice is not to wait until you're at the end of your trajectory on death's door and then have a team come in to help you through that process. The point of hospice is to be a support for you, the patient, as well as your family as you're going through the terminal process. So you can be all the way up here and call in hospice to be a support, because hospice includes equipment like a hospital bed, because some people, they can't physically get up and move around the house like they used to. It can include supportive services like skilled nurses to come to help with the medical aspects of that person's dying, home health aides to help with things around the house, because if you're tending to this person, you don't have time to do the shopping and the this and the cleaning and the cooking. Or even they can help you just with the patient themselves, the home health aide, and their hygienic needs, and spending time with them. Hospice includes spiritual care. There's a spiritual care team, so there are chaplains and ministers who can come out and pray with the patient, pray with you as the family, as a family, and then support you. There are medications that are associated with hospice, and part of the hospice benefit is also that you're not really treating anything anymore. And let me be specific when I say that, because people kind of get a little like, what do you mean? Like, you're abandoning us medically. What we mean is that we're no longer trying to cure whatever it is that is affecting you. So if you have cancer, we're no longer trying to cure your cancer. That doesn't mean that you can't have access to palliative services. And what do I mean by palliative care or palliative services? Palliative is palliation. It's how can I make this person better? So somebody may have cancer, and it's a mass is compressing on some part of their body that is causing untold pain or obstruction, and they can't breathe, they can't talk. And there might be a way for them to have palliative radiation or palliative chemotherapy or some kind of other palliative measure. And so while I'm giving them radiation, I'm not giving them the radiation to cure the cancer. That's not what that's doing. The palliation may be just make it small enough, because it's already spread, or we already know that this person is going to die of this disease, but it might make it just small enough that it will be less uncomfortable for that person. We're not curing it. It's just enough to keep them comfortable. And palliative services too are available as an adjunct to hospice services, because, the dying process can be, sometimes it's painful. Sometimes it's just hard on the family. Somebody has to take care of this person. Right. Somebody has to cook the meals and help clean them and help spend time with them. Things like Alzheimer's, when someone is diagnosed, the trajectory can be anywhere from 8 years to 10 years before that person eventually dies due to the complications of Alzheimer's. But that's just sort of an average. The standard deviation can be 10, it could be 20 years that person is ill with a particular condition. And so the hospice benefit is available through Medicare Part A. And if that person has Medicare Part A, then they have access to hospice services. There are other sort of organizations too that, through, and if anyone has any questions or has any needs, I can connect them with some geriatric services or social services and some resources if there are other people who don't have Medicare or who have hospice needs, and you would like to know how to have a team kind of surround you to help that person through their dying process. So there's a stigma about dying, and there's also a stigma about hospice, that somehow calling in hospice is causing the patient to die, whereas hospice is coming along with a patient who is already dying. They're in a terminal process. It could be usually journey to 6 months or less. The technical definition is that person has a prognosis of 6 months or less based on whatever their medical condition is. And so if they have that prognosis, then we can say we need this team coming along with them. But it can be more than 6 months. Like if they have a really severe illness and we know this person has a year left, some kind of cancer or something like that, this person may only have a year. We can call palliative care in, we can call hospice in to start consulting and pull a whole team around them, around the family, to aid them through this process. And to your point, Tisa, most people want to die at home. Yeah. Most people want to be pain-free. Yeah. Most people want to be surrounded by their families or friends or loved ones. And so those are the services that make that kind of death possible. They make it possible. because by yourself trying to take care of someone who's dying, very difficult. With a team, it can be done. And that's what hospice is there for.
Wow. Wow. All of this, and again, I think it's such good but difficult information, right? Just the discussion isn't easy. It's uncomfortable, but it's so necessary. But I want us to end on a higher note. And I shouldn't even say higher note because let's destigmatize it, right? So it's not a high, low note, but on a broader note about prevention, right? And you specialize in preventive care. And we have a few minutes left. Some of this, all of this is really about preparation, being prepared. But I think, and I guess can be included as a part of prevention, right? So you're preventing your family from being in crisis on top of dealing with what could be your medical crisis.
That's right.
By adequately preparing. So it's an act of love. And that's why I like to say that, that this preparation is an act of love. When we take care of our business beforehand, it tells our family that I thought about how much you love me. So I don't want you to be suffering either if I'm dying. Both of us don't need to be suffering. If I'm dying and leaving here, I don't need you to be suffering, because not only are you grieving this loss, but you're also stuck with trying to make decisions that you are not even emotionally prepared for, and then add educationally ill-equipped to even know what to do.
Yeah, we're throwing these acronyms out, and
they're throwing all this out, and you're in the heat of the moment. You're between snot tissues, trying to make a decision that is just so hard to make when you love, right? And you're losing people you love. But to me, it's all a part of prevention. But also, just talk to us about preventive care, especially with our men. You told us last week about how men die at least, at a minimum 5 years, live, I should say, 5 years less than women do. So that's what I was going to die 5 years earlier, right? Than women do. And then how oftentimes they end up not coming in until it's too late to really do anything with them. So, help us understand just how this preventive, and you hear about all the time, prevention, but maybe again, there's a different way we can think about this that can get our men to understand why this preventive care is so critical.
So often what men will say, especially at the end of their lives, is that they don't want to be a burden. A lot of men, that's one of the reasons why they don't go to the doctor. They just want to keep toughing it through. They don't want to complain about what their issues are. They just want to deal with it internally and just keep pushing. And one of the hardest things for them to do at the end of their lives is to be dependent on other people. The concept for them, for a lot of men, is very, very difficult. And so, there's this thing about just handling your business. You know what I mean? And a lot of men, they handle business financially. They handle business with family members emotionally. They handle business with their businesses, with church, with all the other things that they make priorities for themselves. They handle their business, raising the kids. They kind of do what they're supposed to do what they have to do. And, what I'm encouraging the men who are listening to this, or family members who are going to be sharing this with the men and their families, is that you encourage them to see this as handling their business. We talk about, end of life and how you plan a funeral and all that kind of stuff. But that period right before then, it could be years before, it could be months before that period. So handle your business when it comes to how you want to die. And part of handling your business is telling your family what you want and what you don't want. And if you don't want tubes and lines and this and that and things, and you don't want to be in the hospital and this and that, and you want to be home, that's handling your business. And there are ways for you to be home and comfortable, and you're not a burden on your family.
Right.
Your family, you're surrounded by your family, you are loved by your family, you're not a burden to them, because they have the resources that they need to help take care of you, so that you get your goals met of being around them, and they have their needs met by getting help in taking care of you. So this is a part of just your, you as a man handling your stuff. Like, just get your ducks in a row, get your paperwork in order, for your family. A living will is free. Go to the website, print it out. It's absolutely free. There, you don't have to have a lawyer sign it. You don't have to. You write it down, you sign it, you have your healthcare proxy sign it, a witness, you're good to go. It's low cost, low risk, and it's the value for your family is incalculable. They will thank you in many ways that you won't even know about. But if you have that document in place, that's handling your business and taking that one burden off of them at a very trying time at the end of life.
Thank you so much, Dr. Christina. We
I
have
love
1
it.
minute left. I so appreciate you spending time with us again from your busy schedule to just give us some good information about how can we deal with these health crises and be adequately prepared and take better care of ourselves and handle our business. We focused on men, these last 2 weeks, but everything that we've said applies to everyone, right? It's not just for men, but we wanted to focus predominantly on men because of some of those disparities that you talked about. You guys, Dr. Christina, she works for Maplewood Family Medicine. That's it, right?
Yes, that's it.
Okay. And she's also on faculty at Overlook Family Medicine. I don't know if she's taking new patients, but let me tell you,
We all
obviously you can see that she knows her stuff and she understands our community and she understands, and community education is so critical to her ethos. And so she's passionate about it. So, reach out to her if you're looking for quality care. Again, she already told us to start having these discussions, leverage, those opportunities that, come up with movies, right? That come up in different ways so that we can start having this conversation because we want to be better prepared for what's inevitable. Thank you again, you guys, for joining in. Please be sure to share this on your page. Connect with me on my ministry page, TJ Nance Ministries, which is on Facebook, also on IG. And just let
me. I really appreciate it.
Yes, we appreciate you so much. Okay, take care, everyone.
Good night.
Good night.